Good afternoon, everyone. This session is ready to begin. Sterling Petersen from the Utah Department of Health will moderate this session. Sterling, you have the mic.
Thanks, Charles. We're going to just dive right in here. We apologize for starting a few minutes late, but we have Caprice Edwards here who will kind of start off our session today, and she leads the system development activities for NAFSIS. Did I say that right? As the systems director. She was previously of the Association of Public Health Laboratories, and I'll turn the time over to her. Caprice?
Great. Thank you so much for having me. I'm excited to be here to share the work that we're doing with the vital records community, and specifically the updates coming to our STEVE system and the FHIR implementation. So if you don't know, NAFSIS, it stands for the National Association for Public Health Statistics and Information Systems. We represent the vital records community. There are 57 vital records offices throughout the United States. It includes the 50 states, the 5 territories, New York City as its own entity, and the District of Columbia. So it is a federal mandate that there is no national database of vital records. It is a state right. Maybe that's not the right word, but it's a state function. So the jurisdictions or state, I'm going to use that term interchangeably. The jurisdictions then are left to write their own laws. So the jurisdictions in effect have complete legal proprietor rights over the information that they're collecting and maintaining. Not only are they responsible for maintaining the registries, but for also registering the events and issuing certificates. Just a nice broader picture of us. We recently updated our vision and our mission. A healthier world, a healthier and more secure world through vital records. If you think about your birth certificate, you use that to get your passport or your driver's license. But there's also a lot of health information that's collected in the birth and death certificate and the other vital events as well. So one of the major features with the jurisdictions is, we're a very transient population these days. A lot of times people don't live and die in the same state, especially in jurisdictions where the borders are very close. Like I'm out of Maryland. I know many friends who were born in Washington, D.C., and yet their parents resided in the state of Maryland. So when an individual is born or passes away outside of the jurisdiction of birth or of residence, the jurisdiction that records that vital event needs to share that information for public health purposes, statistical purposes, and overall fraud prevention. So before electronic systems existed, this was a completely paper process. So the vital records offices would literally just file away records for other jurisdictions, residents, in a mailbox, and then they would ship them out once a year. So it was a very antiquated process for her. Not that long ago did it become electronic, but when the vital records offices are sharing the information with one another, one of the biggest takeaways is that the jurisdiction that recorded the event or the jurisdiction of occurrence is the owner of that record. And so the state laws that are applicable to that jurisdiction's information, even when that record is shared with another jurisdiction, that record is still bound to the jurisdiction that created the event, the registration of that event. Those laws still apply to it. So to help facilitate the exchange of all of this information, all of the jurisdictions have signed into what we call the Interjurisdictional Exchange Agreement, or IJE. This IJE document is really a data governance document that dictates kind of what I just explained, that the jurisdiction of occurrence or the sending jurisdiction, that their laws take precedence over the recipient jurisdiction. So if I'm in South Carolina and I have a baby and I actually live in North Carolina, South Carolina will send North Carolina a record that I had a birth in this state and that their population's growing. So there's a lot of different cases and scenarios in which a jurisdiction would need to send out information. Each jurisdiction, like I said at the beginning, they all have their own laws around what information is collected, what information is allowed to be shared. So we use our information exchange platform to help facilitate this agreement. They're able to filter out or redact fields that they are not allowed to share. And I know that when I first came to Vital Records, I thought just that piece of paper, that nice, pretty, you know, with the embossed and that stamp of the state seal, that was really all that was collected. But there's so much more information collected. A lot of health information from the mother-baby worksheet and from hospital systems. There's just so much more information in what's called the medical portion of that record. That legal portion that becomes a certified copy of birth, that certainly is used for legal reasons, citizenship, but there are so many other fields. So the jurisdictions have control and can select what to share and what not to share. When it became electronic, it wasn't just a piece of paper that they were mailing in a box that they had redacted fields from, but it's an electronic piece of information. And once that's been integrated into the residence jurisdictions database, how do you keep control of that? How do you know who's allowed to access it or not? And so the jurisdictions, they all agreed that when the shift to electronic happened, that they wanted to be able to maintain this functionality that they were able to control so readily on paper. Most jurisdictions now do have an electronic birth and death registration system, if not a combined system. So they're sending this data rather than annually, they're sending it daily or every other day. It really is up to the sending jurisdiction to decide how frequently they want to send out information. To do this, we use, we call it STEVE. It's the State and Territorial Exchange of Vital Events. And this system was really built to only facilitate this agreement. It allows the jurisdictions to send information to one another. And we also work with NCHS so they can also receive information. It is a web-based system in its current iteration, which it previously was not. It was a server installation. And so being web-based just makes it a lot easier for jurisdictions to interact with. It also is HIPAA compliant, hosted on the Ames cloud. The file format right now in its current state is a fixed width file format. It has been this way for 20 years, maybe. I mean, it's been a long time that it's been in this fixed width format. So we are looking at updating, and it's not an easy just light switch, right? So we're trying to figure out how we can bridge that gap and make FHIR messaging possible and still allow the jurisdictions who are not ready to share FHIR messaging or to receive FHIR messaging to still use that fixed width file. As described earlier with the different jurisdictions' laws around who they are or not allowed to share specific fields of information with, we use mailboxes. So if you really think of it like a postal service, jurisdiction is going to send a record and it's going to have an address and say, please send to this state. And Steve will be able to pick that up and send it. When the jurisdictions are creating their mailboxes, they are also setting filtering and routing rules. These filtering and routing rules basically replace that redaction. So they're able to say, yes, I want to send these specific fields, or no, I don't want to send these specific fields. And through the mailbox configuration, they're also able to say, I want to send these specific fields to this state's vital records office, and I want to send these other specific fields to this, to NCHS, for example. So they're able to control through one file, they're able to send it to all these different locations. And so by having this easy way to facilitate this data exchange with the security of the data governance document of the IJE, it really has become a seamless way for jurisdictions to send information, not only to one another and not only to NCHS, but to other public health partners. I do want to call attention to that last point I made here about auto routing. Rather than a jurisdiction having to upload the file multiple times and say, send this to these 50 different entities, they upload it once and then the file is able to go to all the locations that it needs to go if it was established in the filtering and routing rules. So I just have to do a little legwork up front and say, yes, I want all these different states to receive it. And I also want these different, a cancer registry to receive it or a birth defects registry to receive it. there are lots of different mailboxes to configure. Some of the challenges, of course, funding is always up there for public health programs and technology especially. In today's day and age, I know that there's a lot of interest, especially on death registration and the process that goes into it. So I'm, as terrible as the pandemic is, and certainly why we're here virtually, I do hope that it brings to light some of the issues that could be addressed with some improvements to the technologies in place. And then, as I mentioned earlier, it's not a light switch. So these registration system vendors, they certainly have a variety of approaches. So some of them are very agile and have kept up with the times, but others, they built it 10 years ago, they've walked away from it, providing minimal support. And so figuring out how these systems can continue to be updated and maintained is a challenge for our members. They are, if not into a second, a third generation system at this point in time. So the evolution of the systems has certainly progressed, but it will not be a light switch to update to FHIR. There are some jurisdictions that are funded specifically to work with NCHS on the FHIR implementation standards. But I'm hoping that by bringing it to Steve and having Steve be this translation tool and this data exchange platform, that they're really able to tap into FHIR when they're ready to, but that they can still share information through the IJE. And then I've kind of been hinting at this all along, but overall, just the timeliness of registration. I know with the pandemic, there's been a lot more attention on death records and the death registration process, but there are so many different data providers participating in this overall death data life cycle, and the systems are not connected. I've heard a funeral home director tell me that they have 2 screens up for 2 systems, and they type in one system and then they type in the other. And so we're really trying to reduce that through working with our members and NCHS on all of this. So for our future growth, there is always room for improvement. If there's not, then take a closer look. So we certainly know that with our Steve mailboxes, they're not being utilized to the full extent that they could be. It's a lot of upfront work that has to go into place to get the mailboxes established with the right filtering and routing. And you also really have to take that, a fine-tooth comb to make sure that as the legal proprietor of this record, that I'm only sharing the fields that I'm allowed to be sharing and with the right group. So it certainly is no small task to get the mailboxes set up. So that certainly is something that we're working on with just our members. And then also I've talked several times now about Steve on FHIR and how we are working with the NCHS implementers community, and I will call it an endeavor. They are great to work with, but it's not an easy, quick changeover. So certainly will be years in the making, and we'll be excited when all the jurisdictions are on board and able to share and exchange FHIR messaging. But in the meantime, we're certainly working towards advancing that. We're participating in the HL7 Connect-a-thon this September. We've participated in past Connect-a-thons and certainly anticipate participating in future Connect-a-thons as well. And then another just overall goal is that we want to increase the access to death records for surveillance purposes. COVID certainly has shed a lot of light on the need for this information in a timely manner. And there's a lot of information, as I said, collected not only on a birth record, but on a death record as well. And all of these pieces of information, if you think about them, they're kind of the bookends of someone's health record. The birth event is the first event, the death event is the last event, and the jurisdictions are collecting those final endpoints. And so how do we weave all of that information together so that way they're not just bookends, but it's a true collaboration across someone's life. So I know that there's a lot of variance with the jurisdiction's laws around who's allowed to access what information. And it's certainly always of the utmost importance to these vital records offices to keep everyone secure. They take it very seriously that they are responsible for this data. And it's It's vital. I know it's kind of cheesy, but vital events are vital. We have to know what's going on with the health of the population, the births, the deaths, and what's causing them or causing them to not happen. So there's a lot of public health programming and other just statistic stuff that happens through vital records. And I kept it pretty short and sweet. So if there are any questions, I haven't seen any come through, but feel free to reach out to me. There's my contact information. You can read more about NAFSIS on our website. But thank you all so much.
Thank you, Caprice. And I'll turn it over to Charles for an update.
Thanks. Thank you, Sterling. So we're having a little bit of an audio issue, and I am going to actually toss to Mike. Caprice, if you wouldn't mind stop sharing. I will load Mike's interoperability slides, and we will see how well everyone can hear Mike as they patch through to my headphones. Wish me luck. I'm loading the slides now, Mike.
Okay.
I think I labeled them backwards, but that's okay. Mike, will you speak? And Terry, would you mind nodding if you can hear Mike okay?
Okay. Sure, I can do that. Hopefully you can hear me.
They can hear you. So we're on slide 1, Mike. It's going to be a silly speaker view for everybody, but take it away. Thank you. Oh, I'm sorry. Let me just say, Mike. This is Mike O'Neill. Mike O'Neill is the CEO of Medicasoft and is here to present advancing healthcare data interoperability using FHIR. Thank you, Mike, for your patience.
No problem, Charles. Thanks. And well, you know, in these interesting times, we've had to make all kinds of technology accommodations. So if you can hear me fine, then we'll all be fine here for this. So I'm happy to go through some fundamentals of FHIR and making FHIR useful for making data really truly useful and interoperable. I know we've had our initial presentation. We have a couple more here that are going to talk about or have talked about the use of FHIR data. So I wanted to focus here on just a couple of really key fundamentals of FHIR as a standard that make it useful. So if we're able to look briefly at the agenda slide, next slide, we wanted to touch on a few key FHIR attributes that really make it different as a standard, as a healthcare standard, and then talk a little bit about how you actually use this in the context of some existing solutions that you may have. How would you use it maybe in a new platform environment using FHIR natively? And then also touch on some of the regulations, some of the rules that have come out this year that really promote the use of FHIR. So let's jump into the next slide. And, you know, I do feel like I have to say FHIR is, in the last few years, become such a buzzword and a source of puns, some better than others, about things actually being burning on fire, that obviously what we want to focus on here is a little bit more concrete, and how, you know, FHIR as a standard can help you make the data useful. That includes things like aggregating data so that you have it where you need it, making that data useful in terms of normalization or code set mapping or enhancing data quality, and of course, making it easier to share data, easy ways to exchange, easy ways to make sure that it's interoperable. That if I'm exchanging data with you, we both have a clear understanding of what the data actually means. So if we go to our next slide, the first really two main features that I wanted to highlight here is actually the API portion of the standard itself, the application programming interface. From a software architecture point of view, really independent of healthcare or any vertical market, the API part of the FHIR standard puts it just squarely into the mainstream of what we would all recognize as modern web and cloud-based software design. FHIR is actually, as a design principle, when it started, was developed to be developer friendly. So for people who write software and integrate systems and have to make systems work every day, FHIR has one of its design principles was built with you in mind. As you know, if you are building and implementing systems today, you are often building directly for cloud hosting. You want to include things that will make your applications largely scalable, that allow you to protect security. Let's not forget some practical terms of having skill set in your IT staff to do software development and integration in the first place. All of the things that other industries leverage there, we're now able to leverage in healthcare when it comes to FHIR because of some fundamental decisions made just for the API. First of all, the traffic, the way you communicate with the API is HTTP. This is actually the foundation of all web traffic. The type of interface or API that we're dealing with is what's known as a RESTful API. This is a very standard way that software applications and services communicate with each other today. The types of commands that you can send, the way that you add data or update data or delete things, it's a very, very standard thing. Even the form of the data that comes back to you when you're using the API is a standard that's very common in web applications today, JSON. So from a software point of view, we haven't really gotten to the healthcare unique part yet, just from a software point of view, some really early decisions that the HL7 team that developed FHIR have made FHIR as a standard very easy to use from a development point of view to build real systems that we can use every day to manage our data. We'll go to our next slide. The second main feature at a high level of FHIR as a standard is actually the data model itself. And here, where the first feature I mentioned was in terms of software in general, this part is actually the healthcare unique piece. The data model is what tells us how do we represent the data elements that we want to deal with, including fundamental elements like patients, medications, allergies, and so forth, but also things that we don't always think about, administrative resources, even insurance and claims related data. All of these things have a defined representation in the FHIR standard, and they're referred to as resources. The way that the data model portion of FHIR works is it defines how we specify the data that we want to represent, the details that are important to us, in a way that we can exchange them with others and it will still make sense. To give you just a simple, concrete example, it may be important for you in your application to know that a blood pressure was taken, let's say, on the leg while the patient was seated versus on the arm lying down, and these kind of things, where in my application, it just may be a thing when it's a blood pressure, I would like to know the systolic and diastolic numbers, and that's it. A good standard lets us both represent the right level of detail that's relevant to us without losing the ability to understand each other's data. And so FHIR resources give us the ability to do that. One of the principles that the FHIR standards team took early on was what's often called the 80-20 rule when it comes to how specific to be. And for the 80% of things that make up most of what we do day in and day out, the FHIR data model gives us an explicit way to represent those things. And for the other 20%, the special cases that we deal with on occasion, the standard didn't go overboard in trying to predict and specify every one of those, but it gives us a way to specify an extension. So if I'm dealing with a certain type of data that's unique to me, I have a way that I can specify it, but it won't break the standard. If I communicate it to you, you have a way to at least make some sense of it. So on the next slide, I put both of these concepts together in one simple picture. If we take a look at the combination of the data model, a simple and extensible way to represent data, and a thoroughly modern way in software terms to access and share it, that's a good high-level representation of what FHIR brings to us. Data as a collection of FHIR resources, exposed or made accessible via FHIR API. On the next slide, I thought we should talk a little bit about, given that we can talk about pros and cons of FHIR and how it evolved and so forth, but how do we start using it? In particular, if we have an existing system, and by system, maybe that's an EHR or the database that you use for analysis, but something that you already have in place, then you already have some way of storing data, of representing it. It's probably a unique data model to you. Sometimes we call that a proprietary data model, and you have a way to get data in and out of it. But you may be looking at, let's say, giving an application access to your data via FHIR API, or trying to exchange data with another organization via FHIR API. So a common way to attack this is to put another system next to yours. Sometimes it's referred to as a FHIR server that gives you the standard FHIR API, a way to expose that data, and usually some type of database. But when you start out, that's basically an empty database. You have to go through the exercise, the work of mapping your data model to FHIR. Say, here's how I represent medications in my system, my data model. How does FHIR represent it? And then how do I connect those dots? That mapping work is what would allow, let's say, an application to use the FHIR API, expecting to get back FHIR resources, and then be able to access your data. You have to go through the work of mapping your data to FHIR resources. And so this is a way that a lot of organizations have chosen to get started, to take their existing data and make it available via FHIR API. And by the way, this would be true whether you're in an organization where you do a lot of your own development and IT work. You might do this yourself. But if you're working with a vendor who's going to provide FHIR API for your data, this is an approach that they may take under the covers, take their existing system, map data to FHIR, and put a FHIR API next to it. And we look at the next slide. There's another approach to basically skip or do away with the proprietary data model and then the mapping exercise to FHIR, and actually use the FHIR data model as the core part of your system. And it may be easier to see that in the diagram. We'd say, well, the database, the way we store data, we're going to store it as FHIR resources, make it available to applications via the FHIR API. This could be patient-facing applications, mobile apps, patient portal, provider applications, EHRs, payer exchange. Once I have that data stored in the FHIR database, it's accessible via FHIR API for all of those use cases. And actually, if we can go to the next slide, this is an approach that we implemented here at Medicasoft in our NXT platform to use FHIR natively as our data model. And the approach that you would take then is to take your source data. In this case, I'm showing here on the slides clinical data from and other EHRs, from labs, basically in lots of different formats. Parse those messages and those documents, go through a mapping to FHIR resources, and then store data as a collection of FHIR resources as JSON documents. Once you've done that exercise and represented data, actually in the FHIR standard, if we flip quickly to the next slide, that's something that gives us the ability to then organize the data however is dictated by the application that is of interest. So if it is for patient care, a patient-facing application, or EHR provider, we may be interested in organizing that data into a longitudinal patient record. And that organization of data as FHIR Resources gives us the flexibility to do that. So on the following slide, it's just a recap of this, I know, very simple picture, but it's actually a very powerful thing if you're able to take data from disparate sources, different formats, different code sets, or even level of data coding at all, and end up with that data mapped to a standard set of resources in FHIR, made available to a variety of applications via standard API. That actually puts you in a really powerful position to leverage your data in all kinds of ways. On the next slide, I wanted to make at least a brief mention of the kind of regulatory push, if you will, that's going on that actually is promoting the use of FHIR. Both the Office of the National Coordinator, ONC, and CMS have issued final rules earlier this year. I've not tried to recap the extensive rules there, but just to pull out a couple of aspects that apply to healthcare data interoperability and especially the use of FHIR. So for ONC, there is actually a requirement now that healthcare providers make a core set of data referred to as the U.S. Core Data for Interoperability, USCDI, available to patient-facing applications via FHIR API. And actually, really for the first time in these kind of regulations, it's very specific FHIR release for a specific version of the API. On the payer side, CMS has regulated that payers will make claims data available to patients via FHIR API as well, and also that they'll support the exchange between payers of medical data via API. This would be in the case that many of us have experienced, where you've got medical evidence supporting a claim and then need to send it to another agent or another payer. And so CMS has given a push to help to make that an electronic and interoperable transfer. On our last slide here, maybe we'll just wrap up by summarizing that really, beyond the hype and the marketing power of FHIR, there's a couple of really key attributes of the standard that have made it a really ideal building block for building healthcare IT systems. That is not to say that there isn't still real and meaningful work around the data model and the API, patient matching, data quality, getting complete data. All of these things are still part of the work of building truly useful healthcare systems. But FHIR as a standard has really been a big step forward in helping make the data more useful for all of us as we solve our real world problems. And let me conclude there.
Thanks, Mike, and thanks for being willing to be flexible with all the technical glitches. Our next presentation is from Terry Lynn Palmer, and also collaborating with Mike on this. Just a brief introduction for Terry Lynn. She serves as the Director of Data Analytics for the Delaware Health Information Network, which was the nation's first statewide clinical health information exchange. And with that, I'll turn the time over to them.
Just a moment. Okay. Terry Lynn, do you want to share the slides? And Mike,
yes.
I can. Okay, awesome. Thank you.
Mm-hmm.
Thank you, everyone, for your patience and understanding. And Mike, we're just waiting for the first slide to load. Okay, the first slide is loaded, the title slide.
Okay, very good. Well,
did it go away?
Ready to begin a joint presentation that I'd like to do with Terry Lynn Palmer, who is the Director of Data Analytics for Delaware Health Information Network. And so, Terry Lynn, if we are ready to jump in, we can advance to the first slide following the title.
Charles, can you see?
Yep.
Yes, I can now, Terry.
Okay.
Will you advance to the next slide?
Yes. Okay.
I'll pass
Go ahead, Mike.
I'll pass your next through, Mike. Go ahead, Mike.
Okay, very good. So we should be looking at a diagram actually that's very similar to the presentation that I just concluded. So to use that as a jumping off point, we spoke about the use of FHIR as a native data model, and all of the examples I gave there were talking about clinical data going into the FHIR database itself. With that as a jumping off point, Terry Lynn, if it's possible to jump to the next slide. What we wanted to do here is kind of extend that platform idea and talk about two things very, very quickly here before turning it over to Terry Lynn. One is that FHIR handles more than just clinical data. So there's the ability to store claims data concepts in the data model. And the other is that we can extend the use of FHIR data into the world of analytics and data warehouses that support them. So briefly, if we look at the following slide, the next following, which to just circle that ingestion path, if you will, that intake of claims data, in a similar way to parsing and mapping clinical data, claims data can be broken down and various concepts extracted from the claims data, whether it's medications, cost information, and so forth. That data can also be mapped to FHIR resources and stored in the FHIR data model, which is shown on the next slide. The next thing that we often do in a platform approach for analytics is to realize that the database that's good for supporting transactional applications, things that people use and click on, personal health record, EHR, and so forth. Often that kind of a database isn't ideal for bulk type of applications where we're doing analytics and reporting and so forth. And so one thing that we've been able to build as an extension from the FHIR database is to extract data out of that data model and load it into a data warehouse. And that's actually the last of my slides, Terry Lynn, with a circle around the data warehouse. So where I'm going to hand off to Terry Lynn is to say, at the Delaware Health Information Network, they have implemented a platform just like this to ingest or incorporate both clinical data and claims data into a FHIR database using the FHIR data model, and then construct an ETL process to extract the data that is necessary to support the analytics and reporting that they do and put that into a data warehouse. In this kind of a platform approach, FHIR plays kind of the core source of truth for data and supports the loading of the data warehouse. And with that, I'd love to transition it over to Terry Lynn to talk about how DHIN uses the data.
Thank you very much, Mike. Thank you for explaining the FHIR technology platform that is giving DHIN new and sustainable capabilities. I am Terry Lynn Palmer, the Director of Data Analytics at DHIN. This FHIR platform is exciting for me, and I'd like to share with everyone what this FHIR architecture enables for DHIN's data analytics world of possibilities. But first, let me introduce you to DHIN so you understand why DHIN sought Medicasoft and this FHIR platform architecture. DHIN is a not-for-profit instrumentality of the state of Delaware. As a state instrumentality, we are legislated to administrate the Health Information Exchange for Delaware that was launched in 2007. And by 2016, we were legislated to administrate Delaware's healthcare claims database. Our clinical data centers for the HIE are voluntary. The claims data centers for the APCD are mandatory, and all of the data are different from each of the different payers. And I have two quotes that help describe and illustrate what DHIN is trying to do. So one is, data is more valuable in the presence of more data. And this FHIR platform enables us to take advantage of that. We have been diligent in receiving data and making it more useful to Delaware. The second quote is related to FHIR, and that the data platform is flexible enough to support the needs of all of our providers and the variety of the data that we have. DHIN is now poised with FHIR to unlock the value of our more data. And to give you an idea of that, I can give you a fast forward picture of 10 plus years of data collection that demonstrates the breadth and depth of the data that is being managed by this FHIR. All Delaware acute care hospitals and some from bordering states are in our data. We have all commercial labs and 90%, 95% of imaging centers. And we are more recently exchanging data between our neighboring HIEs, covering Maryland, West Virginia, DC, Southern New Jersey, and Southeast Pennsylvania. I'm sure as anybody knows, if you're trying to interrelate data, such as what Caprice showed earlier, there's lots of variety in that data. So this FHIR model helps tremendously. Our more recent data collection endeavor has been with the claims database. Many of you also have the claims data experience. This slide shows 18 data streams from our Delaware payers. These claims data, along with the CMS Medicare claims data, cover about 60% of Delaware's population. It's building a database for analytics that is now pushing 35 gigabytes a year for each year. And our success is largely due to our strong support from Friedman Healthcare. I think we've demonstrated that DHIN has prepared its data in the presence of more data portion. And before we engaged with Medicasoft using FHIR, we found that our previous platform was starting to feel those limitations. Now that we're with Medicasoft and using FHIR, we've improved our scalability and sustainability. We currently have 18 services for providers and the public. And now, having our claims data, we began our analytic services. Our analytic services began, I think I skipped the slide, there we go. Our analytic services began with the traditional deliverables such as data extracts, analyses, and reports. And as part of the legislative rules, we've have formal processes for data applications, approvals, and data releases. And I have some examples of the early projects, the early adopters for this new service for Delaware. Public health and other state agencies are responsible for healthcare improvements and are using the data quite quickly. And the feel-good part for DHIN is that some of the projects are for organizations that have had little to no access to data previously, such as the Brain Injury and Child Death Review Commission. Two of our projects stand out as beacons for our future. We did a project with the CDC environmental project that required a combination of claims and clinical data. And we're, as many folks are, doing a COVID-19 underlying conditions study that requires also the clinical and data claims join. So with the COVID study, we were able to chip away at one of our major challenges that we have with our analytic services and all these data. And that challenge is permission to use the clinical data. The claims data came with use case permissions and a process for ensuring appropriate permissions. The clinical data has its use cases rooted as early as 2007, but it became unlocked when our data centers agreed to DHIN to share the clinical data for COVID public health analytic purposes. So you can see here this particular study. I'd like to point out the richness of the analytic output for this study. And in our 13 years of depth and breadth of clinical data, FHIR made the findings much easier to reach. And so for 597 persons of interest, we found 115,000 records to distill, 14,000 to distill to 14,000 records, and ultimately the data extract will be flattened to the 597 persons of interest. This still is still underway, and we still have some final answers that we'll have at the end of this week. The CDC study that we were working on is a project, is Environmental Conditions Impact Project, which also combines clinical and claims data. This project relied on DHIN's Master Patient Index that provides the connection between our clinical and claims data. We found the person in the claims data and pulled their relevant labs from clinical data. As part of the study, the CDC is comparing the value of using claims data for environmental impact studies. And if anyone ever read the book or saw the movie Erin Brockovich, you would immediately understand the CDC's interest in claims or clinical data. As I mentioned earlier, DHIN is responsible for both private and public benefits. To this end, and with the assistance of Friedman Healthcare, we are building our public reports. I'd like to make a shout out to Colorado and Rhode Island's APCDEs and many others that came before us. We took advantage of their great examples and leadership in this area. We have 2 pharmaceutical-based public reports. Shown here is our opioid overdose and opioid-related emergency visit activity. We hope to push this pharmaceutical conversation in Delaware with public-facing facts. To wrap up, I'd like to share some of the challenges we are addressing now. Though we have the data, more data, and the flexible FHIR technology, we do not have clear permissions or processes for those permissions for our clinical data. Permissions must accommodate both patient consent and data center consent. We also need alignment among governing bodies such as CMS and state legislature. With the Analytic Services moving like wildfire, we began a 3-year plan. And in this 3-year plan, the vision for this plan is to improve our internal structure and processes, to enable a wide variety of public and private analytic services, and equally as important, by year 3, we want to merge our clinical and claims data into our community health record service and our personal health record service. We believe that FHIR technology will enable this development. The 3rd year activities would include adding pharmaceutical and other claims and cost data to our community health record to assist medical providers in delivering healthcare. Similarly, with the DHIN personal healthcare website, we would combine claims and healthcare clinical activities side by side for the personal health record. This would enable graphs of blood pressure, cholesterol, and blood glucose, patient histories alongside pharmaceutical use and costs for that patient. We'll continue building our analytic services as we move along and improve our data release processes to support clinical and claims data. We'll work with our data centers and state legislator for clearly defined permissions. We'll continue adding data to our more data, and we'll utilize FHIR to maintain our data flexibility and sustainability. With all of this, we'll serve as the public and private partnership for healthcare data to benefit all citizens of Delaware. And thank you very much for having Mike and I come and share with you our journey using FHIR for the DHIN analytics.
Thank you, Terry Lynn, and thanks, Mike. Thank you, Caprice, also for presenting. We have a few questions here. I'd like to go through these. Got plenty of time for questions, I think. Wade asks, regarding the ONC and CMS interoperability rules, Do you think payers will connect the FHIR API to their post-adjudicated claims data warehouses? If so, do you think it could be used by APCDs to obtain post-adjudicated claims and encounters, member enrollment and demographic information, as well as provider information? If so, how long do you think it will take for those APIs to be connected to health plans and insurers, data warehouses, tested, and ready to share data with APCDs? I suppose this is kind of a question for Mike. I don't know if he could actually hear or if he's still on the line, but it's a good question.
It's a good question. Sterling, can you hear me okay?
Yes, I can.
Okay, I'm gonna, and unfortunately, in order to do this pass-through, Mike cannot hear us. He can hear me, but he can't hear all of you. So I apologize, but I'm gonna reread the question and then we'll get Mike's response. So the question, Mike, is regarding to the ONC and CMS interoperability rules, do you think payers will connect the FHIR API to their post-adjudicated claims data warehouses? And if so, do you think it could be used by APCDs to obtain post-adjudicated claims and encounters, member enrollment and demographic information, and provider information? If so, how long do you think it will take for those APIs to be connected to health plans and insurers' data warehouses, tested and ready to share data with APCDs?
Sure. So I do think in the longer term that's a path that we may see. In the shorter term, the CMS regulation actually requires payers to expose data to patients, to individuals, claims and encounter data by January 1st, actually. Although given COVID-19, that's not going to be enforced until July 1st. So the first step will be to expose claims and encounter data via FHIR API to patients by, let's say, next July. There's not a requirement then to make the data available, let's say, to an APCD, but it seems like that would be a natural progression. So I do think in the longer term, that's what we'll see. In the shorter term, medium term, I think that it will be first to let's meet the letter of the requirement to make this data available to patients via FHIR API.
And I have a little bit of a follow-up question on that for Mike. Is it a good fit? I mean, right now, the APCDs, each state, except with a few exceptions, kind of uses a state-specific data layout, and they receive it on a kind of a monthly bulk data dump. Is FHIR really appropriate for that type of mass data exchange? Sorry, Charles.
You're okay. I'm relaying as you're going to.
So this is really precisely why I think it would be an evolutionary thing for, let's say, a payer to provide bulk data to an APCD. One, because the FHIR standard right now is really ideal for exposing data to, let's say, an individual patient or individual applications. Communicating or exchanging bulk data is part of the FHIR Release 4, and that would be coming in the next little while. That would address one part of it, which is how do I deliver a lot of data that may cover, let's say, thousands, hundreds of thousands, millions of patients. That's one piece of the evolution. The other is, it sounds like, as Sterling mentioned, these reporting processes now are kind of fixed in state-by-state proprietary submission guidelines and file formats and so forth. So it's just an evolutionary thing to get away from that. So I'm not to repeat myself, but I think first steps will be for patient-facing applications, or let's say individual kind of transactions that are ideal for the FHIR API as it stands now. Then as the industry, as payers get used to doing API-based exchange at all, and states get systems that can accommodate it, then the FHIR API will be able to support bulk exchange, and the industry will probably be able to break out of the I'm not sure if constraints is the right right term, but the longstanding tradition of file formats and state-by-state submission guides.
Great, thank you so much. We have about a minute and a half here, and I kind of wanted to leave a few seconds for Charles, for him to make a few remarks. Want to thank Terry Lynn and Mike and Caprice for presenting today, and thank you all for attending. And with that, I'll give the last minute over to Charles.
Okay, very good. Well, I'm glad it worked out.
Yeah, thanks, Mike. Have a good one.
All right, thanks, you too.
Okay, thank you everyone for your patience as we work through that. I just wanted to touch on a couple of quick things. I'm now about to tell you that there is a session survey that is attached to this session. Please fill that out. We appreciate your feedback. And then also I wanted to mention that this evening we have networking sessions. I'm hosting one. I believe Helen Figge, who's in the audience and works with Mike O'Neill, she's also hosting one specifically. There's a topic for that one, which is FHIR. It's worth noting that the topics are kind of loose. Mine is new to NAHDO, and there are some others as well. But I'd encourage you all to take a look at that list and join some of us in kind of a networking session this evening. So otherwise, thank you again, and we'll talk to you soon.